Adrenal glands are located on top of the kidneys. If you are to imagine the kidney, two kidneys will have this little triangular little organ called the adrenal gland. They look like a baseball cap or a little hat on the kidneys. Sometimes the adrenal gland can have a growth. It could be cancerous, or it could be a growth that can cause hormonal changes or adrenal changes. Um, and in those cases, the adrenal gland needs to be removed. Now, adrenal glands are well known to have, or adrenal glands are very prone to having what we call metastatic disease, meaning there are other cancers from other organs that can migrate or go to the adrenal gland. And sometimes, for those reasons, the adrenal gland needs to be removed. And the removal of adrenal gland, which is called an adrenalectomy, can be performed robotically or laparoscopically. Robotically, it can be performed with a multi-port or a single port. I prefer to do most of my adrenalectomy with a single port, meaning I can remove the adrenal gland using either one or two holes instead of 5 or 6 to remove to do the surgery. The surgery takes approximately an hour to 2 hours. Blood loss again for adrenalectomy are typically very minimal, less than 100, less than 50 milliliters. Um, we, depending on which side the adrenal gland is being performed, on the left side, the adrenal gland is not covered or is not under the liver. So sometimes on the left side, I can do that procedure with only one port. However, on the right side, sometimes the liver drapes over the adrenal gland or the top portion of the kidney. So even though I'm performing a single port robotic surgery, I may need a second hole or incision to lift up the liver to allow us to get to the kidney and the adrenal gland to remove it. The adrenal gland can be carefully removed from the top of the kidney and removed by itself without affecting the kidney at all. So once the adrenal gland's blood supply is clipped off and cut off, I can then put the adrenal gland in a bag and remove the whole thing. The good thing about adrenalectomy is that there's another adrenal gland on the other side, so all the function and the hormones produced by adrenal gland typically is not compromised when you remove one, because the other one will make up the difference and be able to provide all the hormones that's needed by the body, and the function of the adrenal gland stays the same. Often in an adrenalectomy performed robotically or laparoscopically, the patient is able to go home the same day. There are some patients that need to be monitored overnight and may stay overnight. Recovery from adrenalectomy is typically very quick, typically a few weeks, 3 to 4 weeks of recovery. There may be some associated pain from the surgery and incision that may take a few days to recover from the pain, and patients may need to take a stronger pain medication, but majority of patients are able to take Motrin, Tylenol, or ibuprofen for their pain. Again, the great thing about the adrenal gland, there are two of them typically, and the other one will make up and be able to be functional even if one is removed. Often patients may have what's called a ureteropelvic junction obstruction, or UPJ obstruction. UPJ obstruction are typically found either incidentally or because the patient has symptoms. A UPJ obstruction is when there is a blockage between the funnel or the renal collecting system, where urine is being drained down the ureter into the bladder. Typically, the UPJ is close to where the kidney and the ureter joins up. And this could be a congenital abnormality, meaning there could be a kink or an underdeveloped portion of the tube that drains the kidney that needs to be removed and then repaired and reconnected. There are several reasons for this type of kinking or obstruction. Like I said, it could be from a congenital defect where the development of the ureter and the connection of the ureter and the renal pelvis are compromised at birth, and over time it gets worse, and it declares itself with hydronephrosis where the kidney isn't draining well, and associated with that could be some bleeding, infection, kidney stone, pain, and also evidence of renal compromise, meaning because it's not draining well, the kidney slowly sees that its function is not, slowly sees its function compromised, meaning the renal function is getting worse and worse. The repair of this is done robotically. It can be multi-port or single port. I prefer to do this single port because it's a very small repair and small incision to repair this. And it's not really necessary to have multiple 5 or 6 ports when you can do this with 1 or 2 little incision. So the details of this is that using a robot with a camera and robotic instruments, we go into the area where typically around the abdomen area, go and find the kidney and the ureter and the renal pelvis, find the area that's kinked. Sometimes the kink is just a abnormal insertion or a connection. Sometimes the kink is due to what we call a crossing vessel. There may be a second set of blood vessels on the lower portion of the kidney that could be compromising the connection of the ureter to the renal pelvis. And so what needs to be done is that renal pelvis and renal pelvis and the ureter needs to be freed up, and then remove the kink and cut it out, and then reconnect the ureter to the renal pelvis. Sometimes the renal pelvis is so dilated, meaning it's so expanded, that you need to taper it, meaning you have to trim it so that it can function appropriately. The analogy to this is that if let's say you weigh 500 pounds and you lost 400, there'd be a lot of excess skin and excess tissue that can be very floppy. Same thing with the kidney. If it's been dilated for years, it's very stretched out, and then you need to reconnect it back to the ureter. There could be so much extra tissue that if you leave it like that, it wouldn't drain very well. And so what in that situation, I would then trim or reconstruct the renal pelvis to make sure it tapers down so that it's nice. It looks like a nice funnel that will go down and connect to the ureter for it to heal up. So that's a renal pelvic reconstruction. Often, if there's a slowdown or a backup of urine, there could be stones. So at the time of the surgery, if there are stones within the kidney, I would also try to fish out all the stones through the same incision to make sure we get rid of all the stones at the same time. So the surgery could be, an hour and a half, up to 3 hours, depending on what needs to be done. If it's a simple fix, it's quicker. If I have to do a pelvic reconstruction, I have to fish out multiple stones, and there's a crossing vessel, and we have to fix the ureter and bring it together, it may take longer. Again, because this is not a major surgery at a major blood vessel, there's not a lot of blood loss. Typical blood loss for this is between 0 to 50 milliliters of blood loss. So once the stones are removed or the renal pelvis is reconstructed so that the funnel looks nice and slender, the renal pelvis and the ureter are then reconnected. Once it's reconnected, I put a stent. The stent goes from the kidney down to the bladder. The stent is a silicone tube that allows the kidney to drain well so that the connection is not compromised. Not only that, but it also acts as like a stud, like a piercing. If you get an ear piercing, you need a stud to keep it so that the ear piercing doesn't close up. You keep the stent in the kidney for about 4 to 6 weeks. Of course, if there's a lot of renal pelvic reconstruction, you keep it in longer. If there's not as much renal reconstruction, you may be able, or I may be able to take the stent out sooner. So the surgery, again, anywhere from an hour and a half to 3 hours. Blood loss is minimal. A stent will be placed on the inside. It's an internal stent going from the kidney to the bladder. That will stay in for about 4 to 6 weeks. A stent can cause some discomfort, meaning a stent can cause you to have some pain that you feel up here, that may be just a little bit of pain that can remind you there's a stent on the inside. The stent can also cause the bladder to feel like you need to pee more often. Now, after this surgery, or when you have the surgery, I typically do give the patient medicine to help relieve or minimize some of those symptoms. There are medicine to help the body not feel the stent. There are medicine to help relieve the bladder so it doesn't feel like it needs to pee or try to urinate and try to expel the stent. And that can cause a lot of discomfort. But all in all, most patients are able to tolerate the stent for about 4 to 6 weeks, and the stent will be removed with a procedure where we go into the bladder, we grab the stent and just pull it out. Typically, that procedure is very painless. It takes less than a couple of minutes to perform, and that can be performed in the ambulatory center or in the in the office. Again, the incision for this is relatively small. If it's on the left side, typically it's one incision. On the right side, there may be two incisions because we need an extra hole to put in a liver retractor to keep the liver up, and so it doesn't flop over the kidney if it's flopping over the kidney. All the incisions have buried dissolvable sutures on the inside. On the outside, there'll be skin glue that's impervious to water, so you can shower pretty much right away, and there's no dressing changes or any type of care other than to make sure it doesn't you don't peel it off. But it's almost maintenance free. A lot of patients are able to go home the same day. Some patients may need to stay overnight. And recovery time is usually anywhere from 3 to 4 weeks or 4 to 6 weeks, depending on how extensive the surgery is and how long you keep the catheter in. Ureteral reimplantation and ureteral repairs are performed for patients who have the ureter that have had some type of injury or have had some type of scarring or stricture. And this is anywhere along the ureter from the top end, which is called the proximal ureter, down to the distal ureter. On the proximal ureter, if there is a stricture, often we can remove, if the stricture is small or scarring is small, you can remove the stricture and reconnect the two ends of the ureter. Same thing with the middle portion of the ureter. As we get down to the distal ureter, meaning the portion that's closest to the bladder, if there's any injury or scar tissue in that portion of the ureter, we'll remove that area that's defective and then reconnect it to the bladder. Right? So there's a little difference between where where the stricture and where the surgery for the ureter is, and how and what the postoperative care would be. If it's a proximal ureteral repair that's small, you'll have to have a stent. The stent will stay in for about 4 weeks. The stent can cause pain, discomfort around the kidney, which is minimal, and it can also cause some discomfort in urinary frequency where you feel like you need to urinate more often. The surgery for that usually takes about 1 to 2 hours. The incisions are all small, usually 1 or 2 incisions, and they have buried sutures that are dissolvable in the skin glue on top. So it's minimal maintenance or care for the incision and the dressing or the glue. Um, Same thing for the mid-ureter. Now, for a distal ureteral repair or a reimplantation, there'll be a stent, but because we're reconnecting it to the bladder, there'll be sutures connecting the ureter to the bladder. And because there's a hole made into the bladder, a catheter needs to be placed in the bladder, allow the bladder to recover and heal up from the connection or the reanastomosis. And that usually takes about 10 to 14 days of having a catheter in. A lot of patients from this type of surgery are able to go home the same day. Some will have to stay overnight. Pain is typically minimal, and bleeding from the surgery is minimal. All this is performed robotically. Most of my robotic ureteral reimplantation or ureteral repair will be considered a same-day surgery. Some patients will have to stay overnight. Otherwise, it's a minimally invasive procedure with a relatively quick recovery and good results. For my ureteral repairs, the vast majority of my patients are treated with this procedure and require no additional procedures to correct their stricture. A couple things with a distal reimplantation. If there is a gap that is too lengthy to join the ureter to the bladder, there may be some modifications of the bladder to help mind the gap or to reconnect the ureter to the bladder. Sometimes, if it's a small enough distance, we can stretch the bladder, pull it up, and do what's called a psoas hitch, where we pull an ear of the bladder up and then reconnect it. If there's a longer piece or longer gap, and by pulling the bladder and stretching the ureter won't mind the gap, we may have to cut a piece of the bladder out, form it into a tunnel like an antenna, and then connect the ureter to the bladder that way. And that's called a Valori flap. And again, the recovery time for both of those are not anything very different, other than the fact that because I am reconnecting the ureter to the bladder, the catheter, the Foley catheter, needs to stay in the bladder for about 10 to 14 days. Next part is a robotic sacral colpopexy. This is performed for vaginal prolapses. Typically, it's with women who've had a hysterectomy and their vagina has prolapsed, and that means the bladder has gone in to the vagina, and also the intestines are pushing into the vagina and coming out of the introitus or the vaginal vault area. This is a robotic procedure. Either can be performed with a multi-port or a single port, and this is called a sacral colpopexy. In this situation, an incision would be made, either a single port or multi-port, going to the abdomen or outside of the abdomen in the retroperitoneal space, and pulling the vagina up into the abdominal cavity, and then connecting it and keeping it in place by putting a mesh or something to hold it in place, and then connecting that to what we call the sacrum, which is the tail, the sacrum of the backbone. This procedure takes a couple hours. Typically, it's done intraperitoneally by going into the abdomen. However, if the patient has had multiple abdominal surgeries, have what we call a hostile abdomen, where there may be a risk for injuries to other organs because of scar tissues and adhesions, then this can also be performed in a retroperitoneal approach. And the retroperitoneal approach is performed um, in a single port robotic procedure where we go into an area that's outside of the peritoneum, but still between the peritoneum and the bladder and the vaginal cuff, and then bringing it up to the sacrum and connecting it with a piece of either a vicral mesh or other types of uh, um, of other types of typically vicral mesh to bring it to the sacrum and secure it and to fix vaginal prolapse. The surgery typically takes a few hours, 2 to 3 hours. Uh, this is usually done in conjunction with other procedures um, for female incontinence or a female prolapse. Let's say surgery again, a couple hours. Patients are typically overnight stay, are able to discharge home the next day without a catheter if you're able to urinate, with a catheter if you can't urinate. The incision is closed with dissolvable buried sutures, and the skin is closed with a skin glue that is virtually maintenance free, where there's not much care to be performed. It's impervious to water, so you can shower pretty much right away. Um, and this procedure overall has minimal blood loss, less than 50 or 100 milliliters of blood loss.